the Tennessee Commission on Aging and Disability. I am filling in today for Sydney Enns. Sydney is unavailable to be with us due to a death in her family, so please send your thoughts and prayers to Sydney. Hopefully she'll be back in the office, I don't know, next week, but maybe after that, and you all can reach out to her if you would like. Today we're going to talk about navigating dementia with volunteers. So as with any of the training, like I said, had mentioned earlier, this is a supplement to what you are already doing. It is not intended to replace anything. Always talk to your supervisor before you make any changes. There will be some resources available online that you can, and some links at the end of the slide. At the end of this presentation, after this recording is ready, I will send all of this over to Sydney, and she will be sharing it with everyone that registered, and then also posting it in the resource library as well. So you will get the slides, so you don't have to frantically try to take notes. I don't want everybody stressing out over that. If you have questions, you can reach out to in the chat. Amanda is going to monitor the chat for me so I can be focused in on you all. So if you have any questions, feel free to pop them in the chat and we will get them answered at the end. So let's get started. So what we're going to go over today, we're going to talk about just some basic dementia education, give you all a little overview of dementia and how it works, talk about some treatments that are out there, give you some communication techniques. So if you are working with people in your centers or with other volunteers or other people in the community that you might suspect have dementia, you kind of have some communication techniques. And then we're just going to talk about what you are going to have to kind of figure out if you come across a volunteer who you might think may be suffering from a mild cognitive decline. Obviously, it's not our place to diagnose anyone, but you can have some little resources and tips on if you think you might come across somebody that's having some issues. So let's just start with education. Fun facts about the brain. So here are some things that you can hang on to, and you can quiz your family and friends with it later. So the human brain weighs roughly 3 pounds. It requires 20% of our total calories burned each day. So 20% of all the calories that you intake every day is used just to keep your brain functioning. There are over 1 billion with a B neurons sending signals at a rate of 268 miles per hour. I'm going to hope that none of you know what that feels like driving at 268 miles per hour. If you do, please don't get on the road with me. But so what, it's just your brain is so fascinating. 2/3 of the brain's energy budget is used to help nerve cells fire or send signals. The remaining 1/3 is used for cell health maintenance. So just like the body, the brain needs to clean itself out by getting rid of things that it doesn't need, and that happens through the byproducts of metabolism. So it's constantly working. Even when you sleep, your brain is still functioning and working, keeping you active and healthy. So before we understand dementia, we have to understand the parts of the brain, so we know what areas of our lives they control. So when they're affected by dementia, then we can understand how that works. So first, we're going to start off with this aqua color right here. This is our frontal lobe. So this is a section of the brain, and it controls a lot of who you are. So it holds your reasoning, your thinking, your planning, your language, emotions, judgment, motor function, short-term memory. All of that is held right there in that frontal lobe. So damage to this part of the brain can cause damage to how you operate and how you function. So there, it's a very important part of the brain, but it's also holds a lot of responsibilities. So any kind of damage to that frontal lobe is going to affect some of those reasoning and thinking. Now we're going to move over here to this dark pink section. This is a parietal lobe. It's towards the top back part of the brain. This is the section that helps you know your right from your left. So it's what engages when you hear something. It holds your sense of smell, your sense of taste, it's your sense of touch, and it is what helps us read, And a lot of function happen within this part of the brain. A lot of your sensory part is within this part of the brain. Now we're going to go down here to this yellow section. This is our temporal lobe. So this is the part of the brain that controls your language and memory. This is how you understand language. This is the part of the brain that is firing right now, just so you can understand what I'm saying. The back side of the brain, so this purple section here, this is your occipital lobe. And this is where your vision and visual processing and color identification are located. So if you look at where it's positioned, it's at the very back of the brain. So when your eyes that are towards the front of your head look at something, whatever they're looking at, it travels all the way to from the front of the brain to the back, and it inverts itself so that it's translated for you, for your brain to recognize and know what it is. So as I said before, the human brain is a fascinating organ, and all of that happens just like in this split second. And then we're going to move down to the cerebellum. So this is down here at the bottom. This is the part of the brain that controls your coordination and your balance, and it's also where your attention receptors are. So it helps you walk, it helps you move your arms, your hands, it's your attention. So that's a very important part of the brain as well. And then lastly, this very small part down here, it's the smallest and virtually the most important part. This is where your breathing and your heart rate and your temperature are controlled. So damage to the brainstem can in fact be fatal. So that's kind of an overview of the brain. Obviously, if you go to school and you study neurology, you're going to get way more in depth, but just wanted to give you a little brief overview of it so you kind of understand how it works and how dementia will affect it. So now that we have talked about the brain and how it works, we're going to talk a little bit about dementia and what is it. So dementia is a group of symptoms caused by an underlying medical condition that impairs cognitive function, causes behavior changes, and interferes with normal activity. It is not one specific disease or a normal part of aging that only affects older adults. So while it is true that as we age, we forget things, forgetting things and having dementia are two completely separate things. So it is not a normal part of aging, and it is a group of symptoms that we're going to break down here as we keep going. So think of dementia as an umbrella. It's a disease that covers many different subsets. There's over 200 subsets. So if you think about it in the terms of cancer, you hear someone has cancer and then you say, what kind of cancer? Is it lung cancer? Is it breast cancer? Is it bone cancer? So just as cancer is the overarching disease, then you have the subsets. Dementia is the same way. Dementia is the overarching disease, and then there are subsets of dementia. Alzheimer's disease is the most common case of dementia, and it is so common that most people interchange the two words. However, they are not interchangeable. Alzheimer's is a type of dementia. Dementia is the disease itself. So they are not one and the same. 60 to 80% of all dementia cases are typically Alzheimer's disease cases. And Alzheimer's is characterized by amyloid plaques and beta tangles. Those are just big fancy words to say that there are things that get tangled up inside your brain and impair it. Symptoms can include impairments in your memory, your language, your visual spatial skills. So understanding distance, how far are you from sitting down? Are you going to miss the chair? Different things like that. The next most common type of dementia is vascular dementia. So it accounts for roughly 15% of all cases, and it is characterized by a disease or injury to blood vessels leading to the brain. So symptoms include impaired motor skills and judgment. So think about it like a heart attack. There's a blockage in the heart, causes the muscle to not be able to work anymore, which causes the heart attack. So similar things happen in the brain. It can experience a blockage and cause memory loss or loss of judgment. Vascular dementia is very highly associated with heart disease. So if somebody has heart disease and has heart problems, their likelihood of developing vascular dementia can increase. So it's just something to kind of keep a watch on. The next most common is probably frontal temporal dementia, or FTD. And for those of you that are older like me, that is not the florist. That is the shortened name for the frontal temporal lobular dementia. It makes up about 10% of dementia cases. So this is the specific type that affects our frontal and temporal lobes. So if you think back to when we talked about the different parts of the brain, your frontal lobe is where the part of your brain is that determines who you are. This is where your personality and your language skills are located. If you've Unless you've been living under a rock, you've probably heard that Bruce Willis, the actor, was recently um, diagnosed with dementia, and then they've come out and said that it is frontal temporal lobular dementia. So that has affected who he is. Some of the reports that have come out now that say he has become nonverbal. So it is a real thing, and it does affect the person. And it is also one of the fastest rising cases of dementia in younger people. So again, Bruce Willis is not what we would consider an older person. He's probably in his 60s, maybe 70s. I'm not 100% sure, but he's not someone that when he was diagnosed that people were like, oh, he has dementia. So it is not just an old person disease. The next thing is Lewy body dementia. So it's about 5% of the overall dementia cases. This is where protein deposits on nerve cells in the brain, and it can cause symptoms of hallucinations, disoriented sleep patterns, impaired thinking and motor skills. There's generally a lot of behaviors that are associated with Lewy body. So if you have someone that is experiencing a lot of these hallucinations, calling out, disorientation and things like that, it is possible that it is Lewy body. There are different types. There are many other types. Parkinson's is a form of dementia, Huntington's disease, just a lot of different kinds. And, it's hard to just say that somebody has one simple type because a lot of these symptoms can coexist. So you could have Alzheimer's and Lewy bodies. So that's what they call mixed dementia. So sometimes people are just labeled as mixed dementia because they're just not really sure because these symptoms can be so interchangeable with different things. So since Alzheimer's is the most common form, we're going to talk a little bit about it. There are brain changes with Alzheimer's, and they're called, like I said, the plaques and tangles. And these cells of the brain literally become tangled and have a blockage, and it restricts flows to the area. This can lead to nerve cell and brain cell death. So this type of damage can occur up to 20 years before somebody is ever diagnosed with Alzheimer's. So let's do the math. If someone is diagnosed with early onset Alzheimer's, let's say I go to the doctor and they tell me you have early onset Alzheimer's. I'm 43. So that means I started having some of these changes in my brain when I was in my 20s. And I don't know about y'all, but when I was in my 20s, I was not thinking about Alzheimer's and dementia. So again, it's very important to understand that this can happen to younger people. And this is not something that we need to just label as, oh, as they get older, they're going to get dementia. That's not the case. As we get older, we can all develop dementia. And it's important to know the risk factors and know what you can change and what you can't change to try to help reduce your risk. So if you look at these pictures of the brain on the screen, if you look at this first one right here, it's very pink. There's not a lot of space between it. It looks very what we would consider a healthy brain, what you would think a quote unquote normal brain would look like. If you look at this second picture, this is a brain with advanced Alzheimer's. So if you notice, it's a lot darker. It doesn't look as full. There's more gaps, bigger gaps between it. So this is a result of the brain cells dying off. So the brain will physically shrink. If you look at this last picture here, you can see it's an overlay of the healthy brain with the healthy brain's in the background and the diseased brain is on top. So you can see the actual shrinkage of the brain. So when we say that those nerve cells and brain cells die off, they die. So the brain actually has physical change. So before determining if somebody has dementia, it's important to rule out other health concerns and symptoms that can mimic dementia. For example, people who have a serious infection like a urinary tract infection may be confused or delirious. Someone might be, oh, well, they have dementia because they're confused all the time, but that may not be the case. They could have pneumonia. Malnutrition, dehydration, those can all lead to people being confused or have delirium. Again, those can mimic dementia, but it is good to understand that might not always be the case. Unintentional medication side effects, medication interactions or misuse, so forgetting to take their meds or doubling up by accident, substance abuse and use disorder, unstable blood sugars for diabetic, somebody had a head injury, kidney disease, any of these things can produce noticeable changes in cognition, but they aren't necessarily signs of true dementia occurring. So the biggest thing to think about is if you've got somebody that's fine 1 minute and then suddenly they become confused, disoriented, or unstable of doing normal tasks, it's likely that you need to seek medical attention. That's probably not a sign of dementia. That's probably something else is going on. Dementia is something you're going to see changes happening over time. So it's not going to be a sudden onset. Because these symptoms of dementia can sometimes be so misunderstood to be something else, it is very difficult to get that diagnosis. So again, that's why it's good to understand and educate yourself on what dementia is. Now we're going to talk about like the different stages. So again, just like with cancer, when you hear somebody has a cancer diagnosis, usually the next question everybody asks is what type of cancer, and then the next question is what stage. That's typically happens the same with dementia. You want to try to classify it into a stage. Again, this can be hard because some of these symptoms can wax and wane. You might, one day they be better and the next day they be a little worse. But there's generally classified, there's 3 main stages and then 7 overall stages. So hopefully all of us are in stage 1, which there is no sign of cognitive decline. I would like to think that that's where I am. Some days a little harder to believe that than others. Stages 2 and 3 are what we would consider the early stages. So the individual usually still live at home, maybe alone. They're still an active member of their community, but they may need some assistance from time to time. They can experience some memory loss, but it doesn't have a huge impact on their daily life. So then you can move on to stages 4 and 5, or what we would consider moderate stage. So the individual is becoming less independent. They may need to move in with a family member, a child, have somebody move in with them for safety concerns. They typically don't need to be operating a vehicle anymore. It's not really safe for them to do that. You might start noticing some of their personality and behavioral changes. Maybe they get lost more frequently, something that they used to do every day, go for a walk around the neighborhood. And now all of a sudden they get lost and can't remember how to get back home. They have poor awareness of their lower half. So they might start having more falls, may need to start using a cane or a walker. Their mobility is starting to decline. So it's kind of that moderate stage. Stages 6 and 7 are what we would label as late stage. And this is where you start seeing more physical problems. So it's a result of the brain dying. So if you think back to those pictures that we looked at, this is where the brain is shrinking and getting smaller. They're needing more help with their daily activities like cooking and cleaning, bathing, dressing. Their assistance goes a little bit more beyond what a family member can do. So typically they might have to have a caregiver 24/7 or possibly even move to a long-term care facility. Um, it's important to remember that just because someone forgets or starts needing more assistance, they always remember how they feel. That never goes away. They might not can communicate how they feel to you, but they still have feelings. They're still who they are. They're just having a little more difficulty communicating that. So keep that in mind when you're working with individuals, but then also if you think you have a volunteer who might be having some cognitive decline and some cognitive issues, they still remember how they feel. They're still a person just like you and I, and they have those feelings. So that's never going to go away. Now we're just going to kind of briefly run through some treatments. Um, there's not really a cure for dementia or Alzheimer's disease. There is a medication that has been approved by the FDA. It's the first FDA approved medication that will affect the pathophysiology of Alzheimer's disease via the plaques. It's called Aduhelm. It is a very expensive drug. It has to be administered intravenously, so it has to be done in a hospital or in a clinic. Medicare is still not 100% on board with paying for the cost of it just because they want some more therapies around it and some more data. But it's about $30,000 a dose. So I don't know about y'all, but I don't have an extra $30,000 laying around to go get that medication. So sometimes, I mean, there's other medications that are out there that will help with the symptoms and some of the different things that happen. But again, there's not really like a drug you can take. You can't go get chemo like you can with cancer and hope that that cures it. So you have to think of other therapies and ways to improve quality of life for somebody that's living with dementia. So some of those therapies could be occupational therapy. This could help with their dexterity and movement, like buttoning a shirt, brushing their teeth. You also want to look at environmental modifications, things that can be done around the home to make it easier to live and walk, clearing pathways, picking up rugs to reduce fall hazards, keeping things in the same location and not rearranging furniture every time you turn around. Because they get in a pattern and they get used to things. And if you start moving things around, that's when the confusion comes in and that's when some of the behaviors can start happening. Making everyday tasks easier. So breaking down tasks into small steps so it's easier for them to understand and remember. And we're going to talk some more in communication techniques about how we need to do that. Try to maintain as much routine as possible. This will help with confusion and decrease agitation. And then music and pet therapy are really, really beneficial, especially later stages of dementia. Music therapy can help with communication. It can allow someone to express how they're feeling, even if they don't have the words. Um, a song that makes them happy. If they're having some behavioral moves, they can listen to that song, and it can completely change their demeanor and help with activities of daily living. So don't discredit music. I just went back to the wrong slide. So again, individual music, some widely experienced symptoms, again, that we've talked about are decreased ability or inability to understand verbal language. These are symptoms that individualized music can help alleviate. When it comes to caring for older adults, it's important to work towards improving their quality of life. The brain uses music to help control stress and emotions. That is why it can calm you down. Just think of yourself. If you're in a mood, you've had a bad day, you get in the car, you put on like one of your favorite songs, and it just immediately changes your mood. The same thing happens with someone who is living with a diagnosis of dementia or Alzheimer's. Again, they're still who they are. They still remember how they feel. Music interacts with every category of brain processing and can be used in a variety of therapeutic ways. Some individuals with dementia can sing after losing their ability to speak. So when you speak with somebody, you have to interpret what's being said. You have to hear it, then interpret it, put together the correct order to speak it back. In music, and particularly a familiar song, that order is already put together and it's tied to a long-term memory, especially if it's a song they've listened to all their life. So that person only needs to recall the song in order to communicate. Again, you can look in their eyes and you can see they can move around if they're happy. If it's a song that typically makes them happy and they don't have a reaction to it, maybe they don't get happy or they have a look on their face, you might, okay, something else is wrong, because this is something that typically generates a positive response. So music is very therapeutic and can do a lot to help with it. Again, the brain is a fascinating organ and plays such an important role in our lives now and as we age. So taking care of it, just like we take care of our heart, we have to take care of our brain. So that's been a lot. That's just kind of the basics of dementia. Are there any questions right now on that before we get into some communication techniques? Okay, we'll keep going then. So being able to effectively communicate with an individual who may be living with a diagnosis of dementia or mild cognitive decline is essential to providing proper care and support. There is no right or wrong way to communicate with somebody living with a diagnosis. The most important thing to remember is they are still an individual who has feelings and a desire to be understood. Just as you and I have a desire to be understood, someone living with a diagnosis of dementia has a desire to be understood. It might be a little more difficult, but they still want to be heard and understood. So when communicating with somebody living with a diagnosis, there's three important things to remember. Communication can happen in the form of spoken word, written word, or drawings. As the disease progresses, these communication techniques will change. So being flexible and patient are essential in working with an individual living with a diagnosis. Changes in their ability to communicate can vary based on the person and where he or she is in the disease process. The problems you can expect to see throughout the progression of the disease can include difficulty finding the right words, using familiar words repeatedly, describing familiar objects rather than calling them by name, easily losing their train of thought, difficulty organizing words logically, reverting to speaking a native language. So maybe their primary language is Spanish, and all of their lives they have talked in English other than when they were a child, and now they might revert back to speaking in their native language. They may not understand English anymore. So that's why it's very essential to know the background of people you are working with. They might start speaking less often or even relying on gestures more than speaking. It's important to remember that when you're working with somebody with a diagnosis, to try and talk about one thing at a time. Don't jump around a lot. You may have to re-explain why you're there to help them. You may have to re-explain who you are. Keep your questions simple and closed-ended. For example, instead of saying, "What do you want to drink?" you may want to give them an option. Do you want coffee or do you want milk? Because just saying, "What do you want to drink?" that's an open-ended question that leaves a lot of room for interpretation. And whomever you're speaking with may not know what their choices are, and so they get overwhelmed and they get frustrated and they get upset. So if you give them an option, they still have that choice, so they're still making a choice for themselves. But they don't get so overwhelmed. It keeps it simple and provides a narrow focus and limits the confusion. So some strategies. So for persons living with a diagnosis, they do not process 1 in 4 words. So think about as I've been talking to you today. If you only heard every 4th word that I said, you would likely have no idea what I'm talking about. Somebody living with a diagnosis of dementia, they only process 1 in 4 words. So in these early stages, some of these characteristics can include their processing speed slow down, their learning time increases, so it takes them longer to do something. They loss of their short-term memory starts happening, and they have difficulty finding the right words. So what you can do is be patient and slow down. Explain what you need or you're asking as many times as needed. Repeat those instructions however many times it takes. Make sure you maintain eye contact so the person you're working with can feel seen and heard. It's important to make sure you're talking to them and not at them. Again, they still remember how they feel. It may be good to have cue cards to kind of describe activities. So, for example, if somebody maybe they're forgetting how to brush their teeth or what they're supposed to do when they get to the bathroom. Maybe if you have a pictograph hanging in the bathroom next to the sink that shows somebody brushing their teeth, that might help them remember, okay, that's what I'm supposed to do in here. So somebody living with dementia can typically still read, but they just can't find the words to communicate. So using some written communication may be helpful. Maybe putting Post-it notes on things. Close the refrigerator, take your medicine, turn off the lights, different things like that. You can have that written communication so they can still be effective in communicating. So now we move on to the middle stages. In this stage, you might see moments of clarity mixed with loss of logic, reason, and perspective. They have more difficulty making decisions. This is where options come into play. Again, do you want to wear your red shirt or your blue shirt? Unable to sequence through a task. So instead of just saying, let's get ready, you may need to break down the task to say, let's put on our socks. Now let's put on our shoes, because they might not understand to put their socks on first. You're also going to see diminish in language skills. So words will not make sense and they'll mix them up. Remember, somebody with dementia only understands every 4th word. So as the disease progresses, their ability to understand what's being said will decrease. Also, there's an increase in poor judgment. They may become more irrational and lack self control in their impulse control. So again, you just start noticing these things happening more and more. This is not a normal part of aging. These are things that you might start picking up on. And if you think you have a volunteer that's exhibiting some of these signs, It's time to start having some real conversations, not only for their safety, but for the safety of others around them. Remember to slow down, make a connection before doing anything, use their preferred name. With older adults, we tend to call them sweetie or honey or sugar. I know me, I was raised in the South. My father taught me it's Mr. and Miss. But if I call Miss Smith, and she doesn't realize her last name is Smith, and she's been called Sadie her entire life, and I call her Miss Smith, she's not going to think I'm talking to her. So if her name is Sadie, and that's the name she prefers, then I need to call her Sadie. It just makes it easier for them to understand that you're talking to them. Limit sharing details. Don't go into your full life story. Just give them the basics. Empathize with them and validate their feelings. If you notice that they're getting frustrated, validate it. Say, I'm sorry that you feel this way, or I apologize that I'm having trouble understanding you. Validate what they're feeling so they know that, okay, this is a real feeling that I have. Just because they can't express it doesn't mean that they don't have that feeling. All righty. Now we're moving into late stages. By this time somebody reaches the late stage, they typically no longer have any short-term memory, and their long-term memory is severely limited. Language skills are decreasing even more, and they may no longer be able to speak or have very severe limitations on understanding what is being said. This is where visual cues are going to be more effective than speaking. So maybe using more words or more gestures than words. So maybe a thumbs up if do you feel good today, and you do a thumbs up, or do you feel bad and you do a thumbs down. They are still that same person that they've always been deep down inside. They just have a difficulty expressing what their wants and needs are. My biggest takeaway is that you can always look at their eyes. You can always tell if they're in pain, if they understand you, if they're following you by looking in their eyes. So make sure you're in front of them. Make sure you maintain that contact, maintain that connection. As we said earlier, music can really come into play in this stage. Speaking in a rhythm or using music, especially when doing an activity like dressing or bathing, can help a lot with it too. Again, being patient and having empathy will go a long ways in this stage. The biggest thing when you're working with individuals living with a diagnosis and their care partners or caregivers is that keep in mind that when you're dealing with them, this is a big change for these care partners as well. We just talked about all these changes that the person that's living with a diagnosis is going through. The same thing is happening to their care partner, or caregiver, or family member, whomever that might be. They may need just as much as assistance as the person you're working with or the person you're encountering. So having some understanding, and again, being engaged. You never know how big of an impact you can have on somebody's day just by being nice and listening. So now, as we move into probably what you all really wanted the meat and potatoes of what you wanted to hear today. In the world of volunteering, we're going to encounter a very diverse range of people in those we serve and those who volunteer with us. Each person brings their own unique strengths and challenges. And throughout our years as volunteer coordinators and managers, you're going to come across various situations that are going to require a delicate balance of empathy, understanding, and professionalism. This is typically or particularly going to come into play when you start to suspect or see signs of dementia in one of your volunteers. As we've just talked about, dementia is a very complex and challenging condition. It is, none of us are medical professional. Well, I can't say none of us. I don't know what all you all do on there. Some of you may be medical professionals. I am not a medical professional, so it is not my place to diagnose someone. I can simply react to what I see and what I hear and try to make a decision based off of those reactions. Again, I can't go in and say, you have dementia, you have to stop volunteering. We have to treat it a little more delicately. And how do we do that? So what we are going to do, we've got some little helpful hints and things that we can do. The biggest thing, educate yourself and those on your team, just like you're all doing today. Learn about dementia and what are signs to look for. Remove the stigma that somebody living with a diagnosis of dementia is incapable of doing things. They're not incapable. They just may need some modifications. Step two, because their abilities may change, you may have to modify their role as a volunteer. See if you can still have them assist, but maybe provide a simpler task for them to do. But approach it as you need them in this role instead of you can't do this anymore. Don't go up to them and say, you can't do this anymore. I can't have you do this. Maybe if you're trying to figure out something else for them to do, say, hey, Sadie, I really need your help doing this. Can you start helping me do this instead of what you've been doing? Because I just really need your help. Again, they want to feel needed. They want to feel wanted, just like we do. So it's fine. It's a fine line to walk, but one that can be done respectfully. Step three, if appropriate, have a conversation with their family. Express your concerns. Again, it's not your job to diagnose them. You're not a medical professional. However, their family may not live close, so they may not see them as much as you do as the volunteer coordinator. They might not understand that, what's happening with them or have any idea anything's going on. Again, it's not to go in and say, I think your mom has dementia and I can't have her work here anymore. But maybe it's to say, I'm having some concerns. I'm noticing some things. Again, as a volunteer coordinator, you have to remove yourself from your relationship with them as a friend to your relationship with them as the coordinator and understand that what you're doing is for their benefit. Is it going to be received well? No, nobody likes to hear that their family members are not doing well. But it's what you have to do as part of your role. Step four, be prepared to let them go if needed. However, remember, they will remember how you make them feel. So it will not be easy conversation, but one that can be helpful and not hurtful. And we're going to talk about that on the next slide on some steps to have that conversation. Provide an opportunity for them to continue to be part of the group. Invite them to participate in activities or meals. Just because they're not able to volunteer anymore doesn't mean that they still can't benefit from the services to stimulate them and encourage them to be active and live as long as possible. So maybe it's just, Miss Sadie, we've got enough volunteers and I really appreciate all you've done. But, I'm not going to need you to volunteer anymore. But I'll tell you what, how about you come back and you help me? And then that way you'll be here. And if I need something, you're still here to help me. Again, they want to feel needed. They want to feel encouraged. So don't say, yep, I think you got dementia. You can't be here no more. And hope you live a happy life. Try to keep them involved. Try to keep them encouraged. So how do you let them go? Not an easy conversation that any of us want to have. Now that you've made the decision that you need to let them go, how can you do that with grace? The easiest thing you can do in this situation is, like I said earlier, let go of the attachment of the difficult situation. You're a volunteer manager. They are a volunteer. You have to understand that this is part of your job and give yourself grace to make this decision. Ultimately, it is what is best for the organization. So first of all, you need to ground yourself in purpose. Your focus as a leader is the mission of the organization, not the volunteers. This is the not so happy side of it. Volunteers are your strategy that you have to meet your mission. So understand that purpose and remove that attachment. Your purpose is to serve meals. I'm going to keep using meals because I'm also the nutrition director. So I apologize for those of you that don't do meals, but your mission is to get meals in the hands of those who need them. Your mission is not to make sure you have a volunteer opportunity for everybody in the community. You utilize those volunteers to get those meals into the hands of those individuals. So you have to understand that purpose and you have to separate that attachment. Number two, if the volunteer is not able to physically or mentally complete the job or task, they are disrupting progress. It's not to be harsh, but at the end of the day, you have to focus on the mission of your organization. So again, if your mission is to provide home delivered meals and your volunteers are no longer safe driving and delivering those meals, they are disrupting that progress. So again, you have to recognize that. Explore the possibilities of a different task. Maybe they're no longer able to drive, but they can help pack the meals. So have a conversation with them about it and not about them to other people. Don't go around talking to the other volunteers about, well, Miss Sadie's just not safe no more. I just can't have her driving. Have that conversation with Miss Sadie. Set aside time to have that and provide them with a choice. Again, we talked about choice. Tell her, say, I'm not real comfortable with you driving anymore because you've had a couple of fender benders. Would you rather stay here and help bag the lunches? Or we could possibly let you ride with somebody and still help deliver. What would you prefer to do? Again, give them that choice. Let them make that decision. But give them choices. Give them choices you're comfortable with them doing. Number 4, it's okay to express how you feel about the situation. When you're having this conversation with your volunteer, tell them if it's making you sad to have the conversation, uncomfortable, worried. It's okay. Be human and explain how you feel about it, but do it in a compassionate way. Don't just say, you're causing problems and I can't have this anymore. You can no longer volunteer. Instead, express your feelings in a way they understand. I'm worried about your safety if you continue to drive to deliver meals. I've noticed you've gotten lost a few times. Maybe let's consider a different task. Would you be interested in helping pack meals or riding with somebody else to deliver? So again, you're having that conversation. You're expressing that empathy. You're expressing to them your concern. And then you're giving them a choice of what they would like to do. They're going to feel like, okay, they really care about me. They're concerned about me. And I can still give back and volunteer. By the time you get to step 5, if you've done steps 1 through 4 and it's still just not working out, you've given them options, you've had the conversations and it's still just not working out, it's time to have a meeting. Schedule this meeting with your volunteer. It needs to be a private meeting. It can be beneficial to have a third party involved. That's typically would preferably be the same gender as your volunteer, just so they don't feel like they're being ganged up on. Odds are that they will know this is coming, especially if you've already done steps 1 through 4. And they know that you're concerned for their safety, and you just have to let them know it's no longer working out. And just for the safety of them and those around them, it's time that maybe they can step down as volunteering. But again, give yourself grace. You've done all that you can do to keep that volunteer active and still to make sure that they're completing the mission of your organization. It is okay to not be okay with this decision, but ultimately you have to worry about all of those that you're trying to serve. And if this one situation is creating a problem and being an obstacle, then you're not benefiting your organization as a whole. So before I jump into resources, are there any questions that anybody has? Okay, I guess we're good. Are y'all still there? Y'all all still asleep?
No questions in the chat, so you're good. Keep going.
Okay, perfect. Thanks. So now we're going to talk about some resources. There are so many resources out there that you can provide to your volunteer and their families on ways to cope with a diagnosis or suspicion of a diagnosis. Alzheimer's Association, they have a 24/7 helpline. They have offices all across the state of Tennessee and all across the country. They have Community Resource Finder on their website, so you can go onto that website, type in what you're looking for, and try to find it, put in your zip code, and try to find some resources. There's also a wonderful organization called Alzheimer's Tennessee. They are specific to Tennessee. They also have a 24/7 helpline. They have 6 regional offices across the state. They have a community. They have support groups that are in the community. They have resources and videos on their website that you, as a person living with a diagnosis or their care partner, can watch. All of these resources are free to access. They have a caregiver academy. So if there's somebody that's just come into being a caregiver for somebody living with a diagnosis, they can go on into these caregiver academies. They have enrichment sessions, they have workshops. There's all kinds of things out there. The majority of this stuff is free to access. You just have to know where to find it. Here at TCAD, we have a ton of resources. One of the biggest things we have are our caregiver tip sheets. It's a set of 18 tip sheets that break down different topics. So medications, hallucinations, getting lost, strategies, different things like that. I have them available in English and Spanish. You can go to our website and download them. You can also send me an email and I can email the link to you, or you can tell me you need printed copies and I will print them off and snail mail them out to you. Again, these are absolutely free. They're good resources. They may be something if you're at a senior center, maybe something you want to put in your senior center that people can pick up. It's just a resource to have. Again, happy to provide them to you if you need them. We also have a lot of different trainings. I do a lot of these trainings around dementia. So if there's other staff that you would like to be trained around dementia or communication, we can do that. So we are here as a resource for you as well. So don't forget about us. There's also tons of other resources online, support groups. Again, suicide prevention. A lot of our older adults that are living with these diagnoses of dementia, they feel like they're a burden to their families. And so we have a very high risk of suicide in our older adult population. So, making sure we have those resources, having suicide prevention trainings. Again, if you're in a senior center, that's a training that is free to you. You can contact the Tennessee Suicide Prevention Network. They can come out and do that training. Something to keep in mind, not only as a caregiver, but also as a volunteer coordinator, is self-care. Self-care is important. Self-care is not selfish. If you have to pour yourself out to all these people all day, every day, you can't pour into others. So you have to refill your cup before you can pour out to others. An analogy I like to use a lot when I do these trainings is if you've ever flown or if you've flown recently, when they go through the safety, they tell you, if your oxygen mask begins to fall from the ceiling, put on your mask first before helping others. That's not to be mean and say you're more important than somebody else. It's just logical. If you're not getting any oxygen and you pass out, you're going to be of no help to anybody around you. So you got to put your mask on first. It's the same thing when you're dealing with individuals, not even somebody living with dementia or Alzheimer's, just older adults in general, or the population, the community, the people you serve, the people on your board, the people in your community. You have to take care of yourself first. So put your oxygen mask on first. Make sure you look for those stressors and signs of stress. Be mindful of burnout. Compassion fatigue and caregiver burnout are a real thing. You've got to recognize what you can change and make those changes in yourself first before you can take care of everybody else around you. There's mental health resources. The state of Tennessee has all of these crisis support phone lines, crisis support text lines. They are free. Utilize your resources. They are all there for you. And then Amanda, who is on the call today, she was very pivotal in our Tennessee Person-Centered Music program. She has given me a lot of music and cognition books. There's a lot of movies out there that talks about the benefits of music and memory. I have seen Alive Inside. It's very great. I have not seen the other ones, but I highly recommend. These are things, again, if you're in a senior center, these are movies you could play at the center. These are things that you could show just to, again, educate those around you. It's a good resource if you want to have a movie day, get some popcorn, watch Alive Inside, listen to some music, have a good music day. These are really good, not only for people living with a diagnosis, but just for people to know in general. And then again, we have all of these resources. You're going to get all of these slides, so you're going to have the links to all of this stuff. Lastly, here's my information. Feel free to reach out to me if I can be of any assistance. My phone number and my email address is on there. If you want these trainings or some other trainings like this, reach out to us. We're happy to help. And do we have any questions? Feel free to take yourself off of mute. We're still recording. If you want to ask any questions, have any comments, concerns. Come on now, don't leave me hanging just because Sydney ain't here. Okay. Well, I'm going to stop recording. I'm going to find the button.